As a cardiologist working with patients, looking at what's happening inside the body, do we all have plaque by the time we're adults?
Not all, but the greatest majority of people, if you go looking with the right tools, you'll eventually find it. Particularly if you use some of the newer testing that's using AI image guidance, you usually find it. In almost every man over 40, I've always found plaque in them.
And what's best case scenario? Somebody that has this slow occlusion, they come to see you, they get on a treadmill, they find out there's a problem there. They say, okay, I'm ready to take this seriously now. Tell me what to do. What's the best they can hope for at that point?
Well, the thing that you're trying to do is first find it, analyze why they're developing that plaque, and then stop it. Plaque is, something that, again, if you're looking for it, you're going to find it. But not everybody with plaque goes on to have a heart attack, stroke, or suddenly die. Those are the people you're trying to figure out. What is the vulnerable plaque versus the more stable plaque? And the vulnerable plaques tend to have a lot more inflammation and oxidative stress, which you can test on blood testing markers. But in my office, I do a lot of functional testing to look at how healthy is the underlying endothelium and by default, the glycocalyx. So testing that looks at nitric oxide availability, testing that looks at central blood pressures, test that looks at pulse rate velocity, how stiff are your arteries. If you have all these markers that the arteries are stiff and you have low nitric oxide, then you're in the process of still likely continuing to lay down plaque. This is not an old problem. So you want to figure out, like, do you still have ongoing fires in the arteries? And this testing can easily kind of help determine those people.
Okay. So obviously, if there is fire in the arteries, we can at least stop it by making the changes we're going to get into. But is there such a thing as reversal? Somebody middle aged coming to see you, they're clogged up. Again, they want to take this seriously and do what you're telling them. Can they actually reverse that accumulation that's happened there?
To a degree, yes. The first goal is find the plaque, stabilize it. If you can prevent a cardiac event, that's winning the game. If you get all the variables right, then plaque has the potential to regress. Will it go all the way back down to completely normal? May not, particularly if the plaque is already calcified. It's not even the goal to get the calcium to regress. The calcium is a scar, and you don't want to disrupt the scar. The thing that you're treating is that it's the plaque that is more soft or more kind of immature, the plaque that hasn't fully gotten a thick cap over it or calcified. You want those softer plaques to what's known as delipidate. You want the cholesterol to be basically pulled out of that plaque. So you're thinking of like shrinking a balloon down. So if you can delipidate a plaque, then the plaques can start to regress or shrink.
All right, let's talk about the specifics. Somebody wanting to go through that process and delipidate. What's the first step?
One, I usually tell people, like, focus on optimizing your glycocalyx and nitric oxide. Because if you do that, that's like putting back up a force field. If you keep your force field up high, you potentially will stop doing damage to the arteries. The arteries aren't going to delipidate and shrink plaques if you continue to do damage to them. If you have endothelial dysfunction, you're still likely laying down plaque. So fix that process. How to do that? It's going to depend, but some general variables are, exercise is extremely important. As you flow blood across your arteries, the arteries are going to upregulate the ability to release nitric oxide. As you eat foods that are rich in nitrates, which are mostly the green leafy vegetables like spinach, kale, arugula, or beets, the nitrates can get broken down into nitric oxide if you have a healthy oral microbiome. And the third lifestyle thing that can improve nitric oxide release is UVA sun exposure. So when you're outside and your skin's feeling warm, the UVA spectrum of light is causing nitric oxide to be liberated from your skin. So do the three things first. Blood tests can point to things that might break your nitric oxide pathways, like elevated homocysteine, elevated uric acid, high insulin and glucose, high asymmetric dimethylarginine. If you find those things, start pulling on those levers and getting those back to normal. So if you get nitric oxide improved, you support the glycocalyx with potentially some supplementation, then you start tackling bucket number two. And bucket number two is the oxidative stress and inflammation. So looking at markers like high sensitivity CRP, LP, PLA2 activity, myeloperoxidase, oxidized LDL. If you start seeing a lot of oxidative stress and inflammation, figure out what's driving that process and shut that down. And then the third bucket is do something to affect their lipoproteins. If they have plaque, there's cholesterol in that plaque. Now, cholesterol is not bad for you. You need cholesterol. Without cholesterol, you're not going to be alive. You need your cholesterol to make your sex hormones, your bile acids, your cell membranes. But if you have too many lipoproteins, think of it as too many cars on the highway, there's more likely to be a traffic jam in your arteries. So use whatever tool to get their numbers to goal. I generally shoot for an ApoB around 70 or less for people who have known plaque in their arteries. So often they're going to be using medications like statins or ezetimibe or one of the PCSK9 inhibitor injections or the new medicine Nexletol. There's a time and place for lifestyle interventions and supplements, but if you have a lot of plaque in the arteries, you're going to want to use the big guns and start putting the fires out sooner than later.
And how often, when you pull out the big guns with a patient, if they're committed to this diet and lifestyle, can they eventually get off those?
I mean, the short answer is, why would you want to treat something and then stop? Because if you don't fix the root cause, you stop some therapies, you're just going to go right back to your baseline, unless you made other significant changes.
Well, that's what I said. If you make the changes, you're hearing what's going on here today, and you're going to drastically change your lifestyle and diet.
Correct. So you may be, somebody who has insulin resistance. You can reverse insulin resistance. That's definitely possible. But that does not mean that you can, automatically come off your statin or your antiplatelet agents or things that are supporting nitric oxide, because those are different variables that are affecting the arteries. You might not need to take metformin or pioglitazone or an SGLT2 inhibitor or a GLP-1 anymore for your, insulin resistance diabetes, but you do need to continue to focus on keep nitric oxide high, inflammation low, lipoproteins controlled through whatever combination. And if you had significant improvements in your lifestyle, then yes, maybe you can start de-escalating some of the therapies, but it's rare that you'd come off everything.
You gave that analogy there. Too many vehicles on the road when it comes to lipoproteins. When looking at lipoproteins, how much of it is the actual number of them versus the quality, specifically when it comes to LDL?
Typically, you're wanting to know the number of particles. It's more important the number than necessarily the size. But if people tend to have a lot of small LDL particles, it's generally either genetic or it's due to insulin resistance. And so if they got insulin resistance, then go start tackling that. Particles predict risk. So, it's a gradient essentially. You have way more particles in your lumen. If you have a damaged endothelial lining, there's always a risk that those lipoproteins are going to get retained there. So you would dial back how many cars on the highway, so there's less likely a traffic jam. It's a numbers game, honestly.
Depending on who I talk to, it seems like LDL as a whole is potentially the bad guy. And certain people in our space are saying it's just a small, dense LDL. In your case, you're saying it's not as black and white as that.
It's not as black and white that, and there's no such thing as bad cholesterol. Again, everybody needs cholesterol, but you don't need lipoproteins dropping that payload of cholesterol off into your arterial walls. And the things that drop off lipoproteins in the arterial walls are the ApoB containing particles. The lion's share of them are going to be LDL particles, but some people have VLDL particles that are high. That's again usually insulin resistance. And 20% of the population has lipoprotein A or Lp(a). That also has ApoB proteins on the outside of the lipoprotein. And that's the issue, is that if you have high LPA, there's no drugs that effectively lower it. You're at double approximately risk of developing plaque in your arteries compared to somebody who doesn't have LPA. So it's the lipoproteins carrying ApoB that are atherogenic. Now, if there's a lot of oxidative stress and they're getting modified, those are the ones that tend to get retained more vivid or more avidly in the arteries. But even quote big fluffy type LDLAs, can still get retained in the arteries. So it's not that everybody with high cholesterol ends up with plaque in the arteries, but if you have plaque in the arteries, it got there somehow, and you're going to want to do something about it. The fact still holds that half the time people have heart attacks, they have normal cholesterol. So cholesterol is not the only thing that you need to focus on. But also, half the time people have heart attacks, they had no symptoms before they had a heart attack. They had a very mild plaque that ruptures. So you're trying to prevent events, and lowering lipids lowers events.
Let's come back to Lp(a). This seems to be getting a lot of momentum in our world. Talk more about how somebody tests for that and what it means. And traditionally, in conventional cardiology, a lot of doctors are saying it's strictly genetic. Other people are saying that you can modify it slightly depending on diet and lifestyle. Expand on how you feel about that.
So lipoprotein A is under genetic influence. Everybody has it, but 20% of the population has elevated serum levels, lipoprotein A. LPA is very similar to LDL, but it has an extra protein on it. apolipoprotein A. That protein allows it basically to stick to the artery a little bit more aggressively. It also is more likely to cause the blood to coagulate or clot. It's a protein produced in the liver. If somebody has significant inflammation, that inflammation can worsen LPA levels. LPA is a scavenger. So if you have a lot of inflammation, LPA is busy. If you don't have a lot of inflammation, LPA may be just setting at its normal set point for your genetic predisposition. So there are not great lifestyle interventions that have much effect on LPA. The only thing that has any real effect at lowering LPA is apheresis. And not very many people are signing up to go into the hospital, get their blood taken out, spun down, and re-injected back in them because it's a short-term fix and you got to keep doing it every couple of weeks. So more popular in Europe, not necessarily so popular in the United States. The only drugs that really have effect in the United States, and it's not significant, is the PCSK9 inhibitors. Those can potentially lower LPA 20, 30%, but that's not yet known if that clinically is significant. So LPA is a risk factor for vascular disease. People who have strong family histories of vascular disease, so grandpa, dad, all your uncles had heart attacks in the 40s and 50s, you probably suspect people have LPA in that family until proven otherwise. The way you test for it, simple blood test. Blood test that costs less than $20. You only need that test one time in your life to know if you have high serum levels at that point. Now, if you have a very strong suspicion, there is genetic testing you can do that can tell you how many LPA genes you have, but a serum test is usually good enough for the majority of people.
If you enjoyed that clip, you're going to want to head over here and catch a full episode. I'll see you over there.
Atherosclerosis is a lifelong disease. It can start in utero, can start before you're born, but you typically don't present to a doctor with symptoms until you're in your 40s, 50s, or 60s. And people can live their entire life, have these plaques, and not know that they're there.